Good evening.
Good
Hi, Dr.
evening.
Mustafa. Welcome. And welcome to everybody who's watching, or anybody who's watching on this unseasonably warm October evening. My name is Dr. Maria Sophocles. You're watching Gynecology, which is our Facebook live stream and YouTube show discussing women's health issues. And tonight we are going to talk with Dr. Rose Mustafa, who is a fellowship trained breast surgical oncologist. She did her general surgery internship at Mount Sinai in New York, and then stayed in New York at Montefiore Albert Einstein Medical Center, where she did a surgical residency, and then completed a breast surgical oncology fellowship at the University of Pennsylvania. She's now at Capitol Health at the Comprehensive Breast Center, where she and her partner, Dr. Lisa Allen, provide fantastic care to the women in this neck of the woods. So we are so lucky to have her in our area, and we're so lucky to have her here tonight because she's probably forgotten more than I know about all things breast. So tonight, it's such a big topic, Dr. Mustafa. We were talking earlier that I was thinking tonight maybe we could kind of focus on screening and on discussing breast density, because so many women now bring me their mammograms and they're confused about what breast density means and whether it's a risk factor for cancer and whether it means they need different testing. So I'd love it if tonight we could focus on that and even talk a little bit about risk factors for cancer, maybe even about some of the screening, the models that we use to help identify women who are at high risk and who may need earlier or different screening. I think breast cancer itself is a whole other topic, and we only have a half an hour tonight, and I want to stop talking and let you do more of the talking. So thank you so much for coming. It's Breast Cancer Awareness Month. October is an important month, if nothing else, to raise awareness about breast cancer.
Thank you so much for having me. I'm so excited. One, that you even do this for the community. I think it's amazing, and it's really a tribute to how much you dedicate your life to breast care. So that's wonderful. So where to start? I mean, I agree with you. I think breast density is so important. One, to just understand, because everyone is now getting their reports, legally mandated. They're getting these reports that say, okay, your breasts are so dense, and everyone comes and says, well, what does that mean? How does that affect us? So if we could pull up a picture, I'd love to show you what it means to have breast density. So the pictures all the way on the right for me is all the pink tissue on the inside of the yellow on the outside. So for instance, that yellow on the outside is just normal breast fatty tissue. The pink tissue on the inside are all the glands. That's what makes up the breast tissue. This is what makes up the dense part of the breast. This is what used to hurt if you got your menstrual cycle monthly. This is what milk is made of. So all of that stuff happens in the glands. Now, when we're young, we have very dense breasts. So when they say you have dense breasts, that's what they mean, that all of that pink tissue is in relation to the fat tissue is much more. As we get older, our breast density should start to decrease. So you can see number 3 is breast. The next one is it's called heterogeneously dense. And then 2 is even less dense. So you see that the glands are less and less in comparing to the fat tissue around it. And then the last one is you have almost entirely fatty breasts, which is good in a sense because you have less tissue that could potentially cause cancer. Now, when it comes to the mammograms, if we pull up the mammogram, that one, perfect. So the one all the way on the right where it says extremely dense, that's what all the breast density looks like. All of that white tissue inside the skin lining is the breast density, and it's bright white. So cancer on a mammogram shows up bright white. So white in a cloud of all white is really hard to distinguish what's actually abnormal. What else can I say? As you get older, like I said, the breast density goes down. So finding cancers in more fatty tissue becomes easier.
So does that mean that so let me get this straight. Everyone has breast density that's sort of idiosyncratic or their own. I could have a woman the same age as myself, and I could have very dense breasts, and she could have very fatty breasts.
Correct.
However, as we age, the general trend, as all women age, is to have their breasts become less dense and more fatty.
Correct.
Easier, actually, as we age, to find breast cancer on a mammogram.
Correct. Absolutely correct.
Okay, just so that's clear.
So everyone fits in one of these 4 categories.
Got it. And which categories require additional testing?
So before additional, I'd probably say the last 2 categories, the breasts that are more dense, heterogeneous and extremely dense breast tissues, I often order 3D mammograms. So everyone's talking about the new mammograms. I'm not sure how new they are now, but the tomosynthesis or 3D mammograms are made for patients who have dense breast tissue because it sort of slices up the images a lot finer. So we're able to really pull the tissue apart, and the radiologist can see through all of that dense breast tissue more with these 3D mammograms. The 2D mammograms, which are the general mammograms, are fine. They're gold standard for fatty tissue and standard breast tissue. So I would recommend dense breast tissue have those 3D mammograms.
Okay, and we have breast density A, B, C, or D. That's how my reports all show. So you're talking about the C and the D.
Correct.
The most dense and the second most dense. But if I'm A or B, I mean, I could play devil's advocate and say, well, shouldn't everybody just get tomosynthesis? Is it a cost issue, insurance coverage issue, or
it's a great question.
Not needed?
That's a great question. So I think eventually all of the mammograms will end up being 3D tomosynthesis mammograms, but they are a different machine. It's a different technology. So it becomes a financial issue. So right now, some women have to pay more out of pocket in order to get the 3D mammograms done. Now, sometimes that's worth it. It's worth to spend the extra. I'm not sure what it is. I think it's different for each insurance company, but maybe 50 to 80, I've heard, dollars. And some women, budget for that because they want the 3D mammograms. I don't know how many years it's going to be. We don't really rule that, but in maybe 20 years, I think all of the mammograms should be, if not will be, 3D mammograms, tomosynthesis mammograms, because it's generally just overall a better study.
Got it. But if you don't have the money to pay, or if you don't have access to a place that does 3D mammograms, and you have breast density A or B, sort of the less dense, more fatty breast, you're okay right now. I think it's more important just to get the mammogram, don't you?
Correct. As long as you get it, correct. And then we can feed off of it. If you're having 3D mammograms and they find something that they're not really sure, then we can supplement it with other studies. We have ultrasounds, we have MRIs, the specialist will take care of that. Sure.
Right. But let's talk about how regularly women should get a mammogram and when should they start?
So that's a very important question. So there are many schools of thought and many large institutions, academic institutions, and national, I think, guidelines that we use. We specifically at Capitol Health, and I think many do, use the NCCN, which is the National Cancer Guidelines. We use those, which establish 40 as your baseline official first mammogram that can be done or should be done. Now, that number changes. So women should get mammograms starting at age 40. However, if you have a high risk in your family history of breast cancers, we tend to start screening at a younger age. You should probably, if you have a lot of family history of breast cancers, maybe see your specialist, get referred to a high risk program, and they can establish and put you on a schedule so that you're getting screened. But 40 would be my recommendation, yes.
Okay. And the people who start getting screened at a younger age, are they people who have breast cancer in their family early? Or in other words, if I have a grandmother who got breast cancer at 85, does that mean I should get screened at a younger age, or I can still start at 40?
You could still start at 40. It's usually 10 years younger than the youngest family member. So if you had a mother, let's say, who had breast cancer at 40, then we would probably start your screening at 30. And then, from there, 50 to 40.
Got it. And about family history, I have patients who come in all the time and they sort of tell me I'm really, really high risk because my dad's sister got breast cancer at 80, or my second cousin has breast cancer. And I think family history is one of those terms that it's really important to kind of hone that down and refine that so people can understand what family history is significant and what family history probably doesn't increase their risk. Maybe we can talk a little bit about that so they understand that they may or may not need additional screening.
Sure. So what's important in our minds when we think of what patients are high risk is we think about premenopausal breast cancer versus postmenopausal. So let's say the average age for menopause is between 50s and 60s. So if a woman has breast cancer in their 70s and 80s, that doesn't necessarily mean that their family member is at higher risk. So premenopausal breast cancer is something that you want to think about. And that's something that you want to share with your providers, because that puts us in a zone where we need to think about it and then maybe apply these calculators that we have. There's these high risk calculators that we can use. There's a few of them. The most well known is probably the Gale model, which is it's calculated on probably every one of the mammograms that they do now. I think it's automated. So that's one that we use. And if you have a strong family history of breast cancer, there are other calculators that we can use. So knowing who had breast cancer, probably first degree relatives and premenopausal breast cancers are what I would end up paying much attention to.
So first degree relatives, your mom, your sister, your child.
Yep.
Okay.
Yep.
Good.
Exactly.
Good. So I think we covered the density part, and I think that's super important because it's sort of out of the closet, so to speak, where it's on everyone's mind. What about abnormal mammos? When someone gets an abnormal mammogram, abnormal is one of those words that drives clinicians crazy because people can be very minimally abnormal or significantly abnormal. And I find myself teaching people about the BI-RAD system and what 0, 1, 2, 3, 4, 5 means. Maybe you could just go over that quickly so people could look for the word and understand relatively.
Sure. So there's really 6 categories. The BI-RAD stands for the breast imaging radiology. It's a language that is easily spoken between the radiologists, the physicians, the surgeons, where we can sort of assess how suspicious this lesion is. So a BI-RADS 1 and 2 are good numbers. That means either nothing is there or something is there, but it looks so benign that we're okay to wait a year. So group those together and get those sort of, great, I'll see you in a year. If you think of the other end, groups, BI-RADS 4s and 5s, those are a little suspicious. Now, statistically, if you have a BI-RADS 4 lesion, right, it'll say it on your thing. It says suspicious enough to warrant a biopsy, okay? BI-RADS 5 lesions will also be very suspicious and warrant a biopsy. Now, the statistics for a BI-RADS 5 lesion to actually return as cancer pathologically is upwards of 95 to 98% of the time a BI-RADS 5 lesion will be cancer. So our conversation when I meet the patients are very different. It's sort of trying to emotionally prepare for that diagnosis versus a BI-RADS 4 lesions. It gets a little technical with A, B, and C, but basically it's about a 50% chance that something can come back as cancerous and something can come back benign. We do a lot of biopsies. Most biopsies are benign. So it's nothing to be too afraid of. But the good thing is, one, that we found it, right? Yeah. And that you're getting referred to where you need to go.
Right. Of course, I know pretty much 0 women ever who are not afraid when they're getting a biopsy.
Right.
It's like when I have to do a cervical biopsy or a uterine biopsy, you can tell them, it's only blah, blah, blah. But I think in everyone's mind, they're always worried about it. And BI-RADS 3 is smack dab in the
middle. Right.
Yeah.
So it's right smack in the middle. So, one needs a biopsy now, the other one needs to wait a year. And the one's right smack in the middle says, yeah, I see something, nothing's making me want to put a needle in it right now, but come back in 6 months. So we split it up and we say, come back and let's see it again in 6 months. And at that time, it's either something stable, and that's great, or it sort of has developed itself into whatever it wanted to be, and we approach it at that time.
Right. So I think that helps women understand what these numbers mean and where they fall into, because as soon as anyone hears anything abnormal, their head immediately goes to cancer. And it honestly sounds like most of the abnormals, literally everything but a 5, is either unlikely to be cancer or not super likely to be cancer. So thank you for explaining, that, helping women understand that abnormal does not mean cancer. There's plenty between normal and abnormal and cancer. Along those lines, and I guess we didn't really think about this, but women also will ask me about calcifications, which could be its own hour talk, of course, but calcifications in 60 seconds or less.
Sure. So calcifications can be normal when they're nice and smooth and round. Basically, they're little white dots on your mammogram. Now, they can come for all different reasons. They can be normal. What we want to know is, when I see calcifications on mammogram, have they been stable? Are they sporadic, one here, and they're the same every 6 months or every year that we're following? When calcifications start to cluster, there's a lot of little ones in one area, or they start to change shape, like one looks like an X or a check, or they just start to look a little funny. That's when we say, listen, something's going on with those cells. Let's just sample it.
Mm-hmm. But it's the clustering or the patterns that is a little more suspicious for abnormality, because that's usually abnormal cells creating those.
Right, creating a pattern. And, we see that. That's why it's so important to get your mammograms annually. Get them every year so we can see if there's a difference, because also just a new calcification, new groupings of calcifications in a line format, or it's doing something funny. When we can compare old and new, it makes such a huge difference to say, oh, those have been there for 10 years. We're okay with it. Versus these have been new for a year. Let's see what's going on.
Mm-hmm. The patients who fail to get regular mammograms in my practice tend to do so because they don't really have a set time, and they go to their primary or their GYN, and then they forget to go a year later, and then it's a year and a half or 2 years. And I find that the patients who are really good are ones who say, every January I get my mammo. I get my mammo every year on my birthday, or I get my mammo every year on July 4th, or whatever it is.
Right.
And so I would encourage people to try to link their mammo to something, whether it's a New Year's resolution and they do it every January or every October because it's Breast Cancer Awareness Month.
Right.
We live in a funny society where we have so many different doctors, between your podiatrist and your gynecologist and your nephrologist and your high kidney specialist, whatever, that you can almost get overwhelmed in this country. And I think certainly radiology centers are fantastic about sending reminders out, but I would encourage women to pick something and make sure that they link it to their annual checkup or GYN checkup or something like that. We don't care if the gynecologist orders it or the primary care orders. We just want you to do it regularly.
I agree.
And I think it's important also to think about when women can and should stop getting mammograms, because in this country you can over test yourself like crazy.
Sure.
What do you
The general guideline is, guidelines state that you should have, if you think that you have about 10 years left of lifetime, or 10 years at least, to go, nothing significant is health guys, holding you back, then you should still get your mammograms. Now, there's no set age. I tend to have the discussion when women are about 75 years old, because the idea is, at that time, if you're not well enough to go through the treatment for it, then why are we going to find the problem for it? So so if I'm not going to offer if someone, I can't bring them to surgery, or they can't get chemotherapy, or they can't lie on a bed for radiation treatment, then maybe don't get the mammograms, because we can't do anything about it. Women in their 80s. But if you're taking care of yourself, then we're happy to get it. And as long as, and we can treat it. We've treated women. We operate on 80-year-old women if we need to. Sometimes there's a small little cancer, we take it out.
Yeah. I mean, the 5-year survival rate for a cancer that's localized is 90%, 90%, something crazy.
Treatable, curable.
Right. It's really, that's, I think, super exciting.
Phenomenal, right?
Changed just in our lifetime,
right.
When we were first training, or even before, I think they had so much less to offer in terms of treatment. And like I said, I think it would be fun to do a second gynecologist, just digging into cancer diagnosis, staging, and treatment, to make sure patients really have an understanding of options for them, and why some women get lumpectomy versus mastectomy, and about biomarkers and what we can do and how that helps. Anyway, there's so much,
so much, right?
Talk forever. You brought some cool pictures that showed some abnormal appearances of breasts, and I loved your idea of saying, look, I know women don't know what breast cancer feels like. Nobody gets that lecture in 6th grade. Here's what breast cancer feels like. And for that reason, many women say, I don't even want to check my breast, because what do I know? I don't even know what I'm feeling. It's just going to stress me out. But there's a lot between that and finding something that's abnormal and wondering if it should be brought to our attention. So maybe you want to show us a couple of them.
Sure. So if you have a couple pictures. So What I want to just say is that, if something is new on your breast exam, then just ask someone for assistance. Say, is this something abnormal? Should it go away? What's the time frame that it should go away if it's something like this? This is called eczema. Patients have eczema. People have it on their elbows, their hands, their faces. So this is nipple eczema, which is very difficult to differ from a very concerning breast cancer. Now, this is something that patients would probably either be treated topically with. So generally, they don't come to me at this stage where they would see their primary or their OBGYN, and they'll try a few ointments and ailments, and then they get better, and that's great. But if they don't get better, they usually get sent to me. And if you can go to the next slide, you can see some very concerning types of breast disease. This is a rare form of breast cancer, but just to show that nipple changes that are like this and persistent, even after locally treated with a cream, with some sort of steroids, that's concerning. So I don't want my patients to know what to do or how to do it. All I want to get across is that if something is new and something is changing and you don't know what it is, just ask for, just start the process of asking for help, and then let the system sort of help you. Right. The next stage, perfect. So this is a pretty aggressive breast cancer called inflammatory breast cancer. I've seen a few this year alone where women will just say, well, listen, my breast felt a little heavy. So you can kind of tell that it's swollen, it's red. It's not really painful, usually patients say, but there's a clear difference between this breast and their natural breast. So I just wanted to kind of give a visual to say, like, if something is happening and it looks a little bit different, just ask for help. And the earlier you do that, the more options that we have, and the quicker we can get you to treatment.
Exactly. And to be quite honest, looking at those, I mean, look, again, most women don't wake up and know what breast cancer looks like. Right. They know something's different, but it's not like a lump. I think most people picture some rock hard lump that's going to feel like someone put, a diamond ring under their skin, and that I'm sure they do. We find that too. But these inflammatory breast cancers are such generalized changes. They're large areas of change. And even if you're not sure and you go to your primary or a dermatologist or a gynecologist, at least you're going to someone who, if they're good, they'll be honest and say, I am not sure, but I want a breast specialist to look at it.
Absolutely.
So
I would love to see something and just say, oh, this is nothing. I'll see you, in 6 months, in a year. Let's just follow up. I would love that, rather than have the other side of it, which is, we're a little down the road. Let's get it going.
Now we don't have options, or we have fewer options. And I think some women delay because they're sure it's nothing, or they dread it's something and they don't want to get the diagnosis. But, this as well. Early detection is everything.
There are so many options when it's early right now.
Can you run through a couple of them? Can we just have a sneak peek at breast cancer thing?
So early breast cancer, the earlier it is, the smaller it usually, it is usually, the less locally advanced it is, meaning breast cancer that's in the actual breast is pretty treatable. We can treat that. We can remove it. Maybe you need radiation treatment afterwards, and then, maybe some medical management. Breast cancer that's been sitting there for a while starts to want to spread. How it would spread is it would start to travel. These cells would travel to your lymph nodes. And once it gets into your lymph nodes, it has access really to the rest of your body, being flushed through the lymphatic system. And that's what makes it a little bit more difficult to control. And it becomes a little bit problematic, harder to treat. We can treat, but harder. And the survival from the, in the end does take its effect. It takes an effect.
Mm-hmm. And chemo is more likely to be needed if something has spread already, because you're treating it systemically. Is that's too generalized, or is that
too? No, it is. But if it's systemic, if it's reached your lymph nodes, we're looking at chemotherapy. But also, we found a way to find out the type of the biology of your tumor. Not everyone's cancer is the same type of cancer. So the type of cancer can also tell us who needs chemotherapy. There are other tests that we can send off the cancer to. It's a company, we can send them off for something called an Oncotype or Mammogram, these type of tests that will tell us what's it's a gene study that will tell us the recurrence risk. Does your cancer want to come back, and would you benefit from chemo? And if that's the case, then that'll be something that's offered. And if it doesn't, then maybe they'll hold off on it.
So does everybody get an Oncotype? How do you decide who gets Oncotyped?
So it's a specific type of markers. Markers are going to matter. So something called triple negative breast cancer, we would not order an Oncotype on. Oncotypes are ordered specifically for patients who are estrogen positive. And this is a result that will come on your pathology report. and HER2 negative. So these are either with lymph nodes involved or not, but those are the type of cancers that we order this Oncotype test for that will give us a recurrence risk, whether it's low. If that risk comes back low, then you wouldn't benefit from chemotherapy, then we wouldn't offer chemotherapy.
Right, because there's chemo has its own risks.
Right.
Right. So Lorraine Meltzer has a question. Just says, thank you so much for doing it. I think it's a statement more than that. It's so educational. Okay, Lorraine, does that mean you've had enough for the night? I'm kidding. I'm kidding. I know. I told you, Dr. Mustafa, we can go and go. I mean,
going, sure.
They just love learning about this stuff. I think it's such a common cancer, and
Right.
it's been very publicized between Susan G. Komen and celebrities with breast cancer in a good way. I think that it's sort of out, like we said, out of the closet, but it also has led to, kind of widespread anxiety about it.
Yeah.
It's certainly what women who come to my practice feared the most. I mean,
Sure.
if you tell them this medication could cause high blood pressure, they barely blink. If
Right.
it could cause mammogram changes, they don't want it no matter what.
Right.
But let's close up with just some risk factors so we clarify for people what are and aren't risk factors. I have people all the time ask me if their microwave is going to cause breast cancer or their cell
phone. Right.
Right.
I hear that often. So I break down risk factors to patients into things that we can control and things that we cannot control. So the things you can't control, we can't control family history, things that increase your risk of estrogen in your body tends to increase your risk of breast cancer. So what does that mean? Well, if I got my menstrual cycle when I was 9 years old and someone else got their menstrual cycle when they were 16 years old, then the patient who had their period earlier and had all those hormones running through their system from 9, 10, 11, 12, all the way up, puts them at higher risk because they're exposed to estrogen more. Patients who go through menopause at a later time, I mean, we can't control these things when you got your menstrual cycle or when you stop it. So those are things you cannot control. What else?
Having a first child over the age of 35 or
right.
birth.
Right. So having, when you have your menstrual cycle every single month. So if you don't give your body a break all the way from when you were 9 to 35 years old, and that's constant hormones running through your system all those years. So that's what the thought is as to when you have your first child. So if someone who has their first child at, let's say, 25 years old, then they've given their body a year basically of a break because you don't have your menstrual cycle for the year basically that you're pregnant. And then if you're able to nurse, maybe another 6 months. So you give yourself a break, a year and a half break essentially from your menstrual cycle, which lowers your risk of breast cancer. If you've never had children and you've had your menstrual cycle from 9 to 60, constantly being exposed to it, then naturally your risk will be higher. Things you can control. So lifestyle, right? I mean, it's the same thing for most things. For cardiac disease, I mean, obesity, smoking, fatty foods, processed foods, all of the things that will give you the same effect on multiple organs has the same effect on your breast tissue. We have to really focus on a healthy lifestyle. It's hard in America sometimes. I know we know what's out there, but exercise, right?
Yeah. Alcohol too.
Alcohol.
I
People always want to know, how much am I allowed to drink? And
my patients always want like a magic cure. Like, how do I lower my risk for breast cancer? Is there some medication out there or something? And I tell them honestly, the best thing you can do is to maintain your weight, which is so hard in this country, I know, but it's doable. And part of maintaining their weight is eating healthy, exercising, and alcohol in moderation. I don't give them really a specific alcohol limit.
I don't either.
Okay, good, because I didn't know a specific alcohol limit. But I think it's part of a bigger picture. We link excessive weight now to 13 different cancers. So it's not just breast cancer. If I have a patient who comes in after menopause with vaginal bleeding and she's, upper 200 pounds, 300 pounds, it's so much more likely that she actually has cancer than a woman who's 150 or 160.
Wow, really? See, I didn't even know that. Wow.
Yeah. So being overweight is one of, the highest risk factors for getting uterine cancer, because the estrogen is stored in fat cells. So you're just you have a backup source of lots of estrogen if you're obese, and you're just feeding estrogen in the uterus. In the uterus, it's like fertilizer. So you're just growing tissue when your body's supposed to not be growing tissue. And when there's no progesterone to counter it, it's like weeds just growing with nothing, and so it will obviously ultimately become hyperplastic or cancer.
Right.
So didn't mean to get off the topic of the breast, but you can see that the link,
It's linked, of course.
and we know that ovarian cancer risk is linked to having never had children, again, never a break from ovulation, and
Right.
letting the ovaries have a break. So it's been so cool to learn from you and to have you share this with us. I feel bad that we barely scratched the surface, but I think that hopefully this inspires a lot of women to look and learn even more. There's a lot of misinformation out there. Do you have a website you like for women to go learn more about breast health or breast cancer?
I do. We often give our patients, so breastcancer.org is very, very simple. It's easy to follow. When patients are just unfortunately diagnosed with breast cancer, also, it's able to split up your cancers to what kind that you have. They also have links for Spanish speaking patients, which I think is wonderful. I have no financial, disclosures at all to it. I don't, but I think it's a wonderful a website. Often, more scientific ones is the American Society of Breast Surgeons is phenomenal. It keeps up to date with all the national cancer guidelines. That's probably more on the medical field side of it, but phenomenal source.
So just breastcancer.org. That's where you would start.
We have tons. I mean, Susan G. Komen does a phenomenal job.
Sure.
We have, I have more. So people who probably come to me already maybe have breast cancer or are being diagnosed. So I have a lot more that are probably not good for general, but you could start there because I have young coalitions ones and triple negative ones, but we don't have to, hopefully.
Dr. Rose Mustafa, thank you so much for joining us. If anyone would like to reach Dr. Mustafa, she is at Capitol Health at the Comprehensive Breast Center. If you can't remember that, you can always get to her through me at princeton.org. I have the back channel to get to this awesome breast surgeon.
Thank you.
And, we are just so grateful. Thank you for all you do for women. And we're just so lucky to have you in our community. So I hope we'll see you again. I hope maybe
anytime. Call me anytime. Thank you so much for having me. It was wonderful. I look forward to doing this again.
I will. Thanks. And have a good night, everybody.
Good night.